Now let's take a look at what do we mean by revenue cycle. And there are 20 elements that I've listed here on this slide. Contract negotiation and provider enrollment in health plans, patient demographics and insurance capture, eligibility and benefits verification, co-pay collection, patient financial counseling, prior approval for certain service coverage, case management, utilization management, charge capture and charge master maintenance, coding and clinical documentation improvement, claims reviews and edits we call cleaning or scrubbing, claim submission, filing for contractual payments and shared risk arrangements, claim status determination, claims attachments, remittance advice and payment posted to accounts receivables, audits, denials, and appeals, accounts receivables follow-up and collections, bad debt charity management, and analytics and reports. So as we consider the flow of these transactions, which are an integral part of the revenue cycle, it should be clear that there are components of revenue cycle management that must support the transactions and where there are opportunities for improvement. Virtually everyone seems to agree today that a critical element in transitioning to value-based care with respect to getting and using better administrative financial information is better revenue cycle management. From the provider perspective, the revenue cycle is a multi-step process, starting with negotiation of contract with health plans to the analytics and reports that should come from the entire process. And those actually feed back into the next and hopefully better contracts negotiated with health plans. And by better, it really is necessary for this contract to benefit both parties. Earlier in a previous lecture, we observed that there must be a win-win situation for all stakeholders to make value-based care successful. Providers and health plans have been very adversarial, but this too seems to be changing, at least a little bit, with the oncoming value-based care programs. Obviously, key aspects of the revenue cycle relate to the flow of the HIPAA transactions, but there are most specific steps that some providers overlook or do not do well, and there are some overarching issues with the way the entire cycle is managed. Let's look at these particularly. Contract negotiation, as we've observed, is going to be very dependent upon convergence of administrative, financial, and clinical data, our next lecture topic. From the administrative financial perspective, however, understanding patient demographics and insurance capture, for example, is the person employed? Is the plan a high deductible plan? What is the patient's response when a copay is required prior to service, etc., etc., has always been good information to have in order to start the collection process prior to service rendering. This practice, however, has rarely been done, but it is now recognized that it may be critical for value-based care. The information about patient demographics and insurance is also part of the information needed to risk stratify your population of patients. We'll be exploring risk stratification more fully in another lecture, but the point here is to capture sufficient administrative financial information that can help identify whether a person will need financial counseling, case management, and other such services. Increasingly, providers are creating payment plans for their patients, for example. Case management is the identification of the issues and barriers that may prevent patients not only from getting better, but uncovering mutually agreed upon solutions to achieve their healthcare goals, including how they're going to pay for their services. Once considered the domain of health plans, some large providers are using case management not as a benefits determination process or a care delivery process, but to begin care plan development to help those in need to achieve desired outcomes. So once we have that information in hand and we actually are getting ready to provide this service, utilization review in a variety of forms is also important and is more focused on clinical compliance. It is often performed by nurses in conference with the patient's physician, primary care provider, if not the physician that's admitting the patient or providing a specialty service, and even the health plan's medical director. Utilization review is an all-encompassing term that includes clinical reviews for medical necessity, discharge planning, care coordination, and drug utilization review. Obviously, what is very much administrative financial is the next series of steps: charge capture and charge master maintenance. Coupled with coding and clinical documentation improvement, these are probably the 4 steps that most directly impact revenue. Charge capture should be automated to the extent possible, but key to success here is determining whether to have systems drop charges at the time a service is ordered or after it is completed. For example, a diagnostic study ordered or diagnostic study results reviewed. Both have risks. An ordered test may not get done, and a charge, if not removed, would be considered fraudulent. An ordered and performed test, however, gets billed even if the result is not reviewed. However, the person reviewing the result may fail to sign off or otherwise indicate the review has occurred. And so in this case, doing it at the point of review and not order could be risky. Barcoding of medications, supplies, and even certain service routines could help this. For especially expensive services or where the barcode process is problematic, radio frequency identification, RFID, is helping. Adding fail-safe measures to how charges are captured is needed, and technology can help here as well with exception reporting routines. Something as simple as a daily run of number of tests ordered versus completed versus read can pinpoint areas for improvement. Not all service performance is associated with an information system in all hospital or physician practices. In these cases, manual posting of the charge is required. Reducing variation in how this is done and a series of checks and balances to ensure proper documentation is essential. An issue for large organizations, even with a significant amount of automation, is inconsistent charge descriptions and practices. Standardizing these to the extent possible reduces misunderstanding, especially as staff move from department to department. An outpatient radiology versus an inpatient radiology, or specialty radiology in this specialty and in that specialty. Part of charge capture must also address the patient's account number. As we start to bundle services or move patients quickly from one service area to another, from a hospital to a nursing home, back to a hospital, to a doctor's office, specialist office, etc., each with different account numbers, it is critical that the service be attributed to the correct account. And remember, the patient identification is not the account number. The account is per the service, not per patient. ChargeMaster is generally an automated tool that lists all potential charges and their cost in a provider setting. In small settings, this information may not be automated. Automating the ChargeMaster enables it to be linked to information systems that post the event of a charge, however it is defined, as already noted. It is critical that the charge master be kept up to date. Just as interoperability between the charge master and the systems in which documentation of the performance of the services is performed is essential, so too is interoperability between the charge master and procurement or purchasing systems. Supply chain is vital in most hospitals and oftentimes in large practices as well. These should be linked to the charge master and charge capture systems. Finally, regular billing audits should be done looking at charges dropped, but to the complete cycle of supply, procurement, service, charge, bill, and reimbursement. Audits should identify potential areas where more intense auditing and workflow improvements are needed. Charge capture and charge master maintenance is very decentralized in many organizations. Auditing can also pinpoint areas where there should be formal and consistent policies and procedures. It must also be recognized that charge capture is often done by administrative assistants who benefit from consistency and regular feedback. Our next couple of steps in revenue cycle are coding and clinical documentation improvement. Coding is the process of assigning numeric or alphanumeric representations, that is, medical codes from the code sets previously described, to clinical documentation. Traditionally, coding was performed upon discharge of a patient from a hospital or upon conclusion of an outpatient office visit, and often sometime after these events. Accurate, complete, and timely coding is critical to prompt claims filing and payment. It requires qualified coders to thoroughly review the documentation for the hospitalization or the visit, consider the statement of discharge diagnoses and procedures, or what is listed on the superbill for a visit, understand the coding standards and requirements for what constitutes a principal diagnosis, complications, comorbidities, procedures, etc. Appropriately message the responsible provider if there are questions concerning these standards and requirements, and then to select the correct codes. Qualified coders are persons knowledgeable about medical terminology, disease processes, and pharmacology. Coding is included in health information management professional education programs at colleges and universities around the country. Training and certifications are also offered by professional organizations. Coding can be aided by computer-assisted coding software that helps locate correct codes and guides usage, by clinical messaging systems, and by access to educational and regulatory requirements, such as through the Internet. Coding originally was performed primarily for mortality and morbidity reporting for public health purposes to identify prevalence and incidence of disease. Coded data is also used for health services planning by providers, often combined with cost and revenue information, when they consider adding or dropping services, such as building a center of excellence for value-based care, and by health plan actuaries for setting rates, and by policymakers to foster proper allocation of resources. Clinical documentation improvement is the function of improving the quality of clinical documentation for many purposes, but today primarily for accurate and complete coding, although it also helps considerably in quality measurement. It may be performed concurrently with service provision and or retrospectively to improve documentation. When indicators of an undocumented condition are identified, physicians should be asked non-leading questions to clarify a potential cause and effect relationship and to address hospital-acquired conditions present on admission issues. Clinical documentation improvement can reduce compliance risks, minimize a facility's vulnerability during external audits, and provide insight into legal quality of care issues. Clinical documentation improvement originated in hospitals, but is increasingly performed in outpatient and office visit settings, especially in support of risk assessment and, as I said before, quality measurement, especially in value-based care. It is also proving to be an effective means to improve reimbursement, just as in hospitals. Let's continue the revenue cycle story. To complete the picture, attributes needed for value-based care. We also need to look at claims generation, remittance management, and collections. Claims reviews and edits, that is cleaning or scrubbing, are often performed to produce clean claims, that is claims ideally without errors. This process is often performed by third parties who are in the business of capturing health plan rules for claims processing and developing software that supports identifying such discrepancies in claims prior to their submission to the health plan. The vendor automatically notifies designated staff members at the provider setting of discrepancies so any corrections can be made. Most hospitals want to achieve the shortest possible days in claims that reflect discharges not final billed or DNFB in order to reduce their days in accounts receivable. So the process of claims scrubbing performed by software managed by such a vendor is well worth the cost. Claims submission, of course, utilizes the ASC X12837 standard. Many hospitals use a third party to make adjustments in the actual claim transaction per health plan rules, which still exist to some extent, and then route claims to applicable health plans. These are called healthcare clearinghouses. These vendors may be the same or different from the claim scrubber. When filing for contractual payments and shared risk arrangements, such as in value-based care, however, different types of reporting may be required and will be specified in the negotiated contract. As previously noted, this may be as simple as use of the ASC X12837 standard as an encounter form rather than a claim. Payment, however, may be on a specified schedule rather than as claims are generated and reviewed and approved. It is very important to closely monitor the status of claims submitted to the health plan, as I said before. We need to respond promptly to requests for additional information so claims do not remain pending for a long period of time or expire due to lack of response, and accurately post payments to accounts receivables as previously mentioned. Managing denials and collections are extremely important functions as well. Denials are increasing as health plans tighten their requirements for medical necessity and conduct more audits and reviews for this purpose. Denials may include both denial of a current claim as well as take back of money from claims already paid where a review reveals issues. This is particularly true for CMS Recovery Audit Contractor or RAC reviews. Steps to manage denials include tracking their financial impact, understanding performance using those CARCs and RARCs codes, and targeting root causes of denials to determine solutions, such as are most of the denials a result of registration errors, invalid coding, failures in claims edits, or other reasons. Increasingly, collections are on the minds of providers, especially as individuals are increasingly using those high deductible plans to reduce their premiums. Collections can be improved by better upfront patient demographics and insurance capture information. Collecting copays prior to service is needed. and offering payment plans, including low or no cost loans, are being successful in some settings. Some providers are experimenting with discounts for upfront payments of deductible amounts. Outsourcing collections is also becoming increasingly common. As payments under value-based care are still being understood, aggressively pursuing payment under fee-for-service arrangement becomes ever more important. Now let's look at not just the revenue cycle steps, but how it's managed, revenue cycle management or RCM. As suggested by the long list of steps that comprise the revenue cycle, many people are involved in assuring that the process works. People with many different backgrounds and skills are required along the path. And they certainly do not all work for a department called revenue cycle. In fact, such a department rarely if ever exists. But just because there is no organizational structure within a provider setting with such a dedicated focus does not mean that every step is separate and not dependent on any other step. Indeed, the exact opposite is true. As such, there must be tight coordination among all parties to the revenue cycle process. There needs to be a general contractor of sorts who oversees the entire cycle. I call this a care coordinator for revenue cycle. Furthermore, given the increasingly clinical nature of many of the revenue cycle steps, increasing consumerism by patients and transitioning to value-based care, this coordinator or general contractor must be a facilitator, team builder, and leader extraordinaire. This individual must instill in the revenue cycle team members appreciation for not only their work and its outcomes, but increasingly recognition of the relationship of revenue cycle to physicians, whose documentation is really at the crux of revenue cycle success, and who unfortunately are increasingly getting angered about documentation requirements that in their view only benefit revenue cycle. Value-based care will impact physicians in new and different ways, indeed allowing them to be more satisfied with their outcomes from both revenue and healthy patient perspectives. Finding champions, providing education, allowing them to help their peers, and ensuring they get regular updates on results can assure physician interest. In addition, patients must also be considered part of the revenue cycle, at least to the extent of being figuratively present. We often think about, what if this was your mother? We need to think about what revenue cycle means to the patient if we want to succeed. If there is one thing in revenue cycle management that seems to be elusive and not always recognized as important, is this concept of coordinating among the disparate parties to the process, and this must change in fee-for-service and for value-based care. So we conclude by noting that there's a lot of articles, blogs, webinars, and all sorts of other things that are currently focused on the topics covered in this lecture. This is a big deal. Many of these articles and so forth repeat the same mantra as we've done so here. So the references used in compiling this lecture and posted here are those that I hopefully find will not only reassure you of the need for revenue cycle management improvements, but give you even more in-depth guidance should this be a special area of interest for you.